coming. My name's Rachel Dovey from Skin Analytics. I'm the NHS lead. So here with Helen today to talk about some of the great cross-collaboration work that we've done with Leicester, Leicestershire and Rutland on skin cancer diagnostics. So just kind of a bit of scene setting, as I appreciate not everyone's going to be as close to dermatology as we are. So what does the national picture look like for dermatology, specifically for skin cancer? We know that it's really hard to get patients to present early. We want them to present early so they have the best chance of survival. We know that patients don't seek help early enough for all cancers, but especially skin cancer. 25% of patients avoided a GP appointment, reported it was because it was hard to get a GP appointment. We also know that finding melanoma and putting patients on the right pathway is also difficult. GPs are generalists, they are not specialists. A lot of them don't get much more than their graduate dermatology, and GPs typically have an 80% sensitivity. So with them not being specialists, patients do end up not on cancer pathways, which means that some melanomas will end up on routine pathways and won't have an urgent referral. Skin cancer as a cancer site is one of the highest referring specialities. So pre-pandemic, it was 500,000 referrals a year. Considering we have a national screening programme for breast, that sits at around 400,000. So it's a huge referral volume to find a relatively low number of melanoma. So it's a bit like finding a needle in a haystack when it comes to skin cancer referrals, which then means a lot of melanomas, 1 in 4, end up on a routine pathway. We also know, I can't believe I'm talking about the backlog this far after the pandemic, but we know that there are NHS backlogs, and particularly in dermatology, routine backlogs and waits are in some places looking at over a year, plus 52 weeks. So when we know that 1 in 4 melanomas are sitting on a routine pathway, this can have a real big impact on their survival rate. We also know that the specialist pathways are congested because we just don't have the workforce. So I feel like I'm using all the kind of Daily Mail buzzwords here of workforce and backlogs and COVID, but it's true. We have 24% of consultant dermatologist posts unfilled, and only of the 2-week wait referral target, only 35% of trusts are actually managing to see their patients within 14 days. And lastly, the incidence of melanoma is increasing. This is partly due to, I think, the pandemic and the latent demand that we've not seen. But skin cancer rates has doubled. You know, I myself was a bit of a sunbed worshipper kind of in the 90s and 2000s, as I'm sure a lot of people were. The rates are going up. We know that there is a direct correlation between, tanning and UV exposure to skin cancer. So the rates are going up. And it's increased by around 1/3 in the last decade. So it's pretty bleak. But what I'm here to talk to you today about is what we're doing at Skin Analytics, which is using AI to enable innovative pathways that can deliver better patient outcomes safely for the NHS. So our solution, Derm, it's an AI-powered algorithm. Derm is the only Class 2A medical device that's approved to be used for dermatology in the UK. The way that the AI works, it's an AI plus a software. So a patient would seek help in the traditional way, whether it's in a GP and get a referral, or in secondary care. We take some basic patient information. We take a dermatoscopic image of the skin lesion, which is like a magnified image of the skin lesion. And then Derm is able to analyse that lesion and give an output. So what that looks like is obviously the patient seeking help. With it being software, there's some configurability to it. So there's elements that can be completed at home by patients, or they can be done in clinic. And then also the same with the image capture can be done in diagnostic hubs at GP practices. And then lastly, the image output. So the AI has kind of multiple functionalities. It checks the image to make sure you've not taken an image of like a table leg. It is actually a skin lesion. It then also checks the quality of that image, and then it will be able to run an analysis on that image and give an output. So we identify 11 different types of lesions. So your most severe melanoma, your cancers, so melanomas, SCCs and BCCs, your precancerous lesions as well, and then also a whole bucket of benign lesions. And the impact that that can have is, as I mentioned previously, with GPs having kind of a sensitivity level of around about 80%, this allows us to catch more skin cancers earlier on in the pathway because the AI operates at a similar level to a consultant. So our sensitivity rating is we set ourselves a 95% threshold. We do perform slightly over that. I'm not going to talk about our performance within this, but if anyone wants to kind of grab me afterwards to talk about the specifics around the AI, more than happy to. So we've been launched since 2020. The company is actually 10 years old. It takes a very long time to build an algorithm that has clinical utility and can be useful within a pathway. So the first few years of skin analytics history was very much about, can we build an algorithm, can it identify skin cancer? Then it's a case of getting the clinical evidence and all the research that we needed to do that, and the appropriate regulatory qualifications as well. And then we actually launched our first AI partner with the University Hospitals Birmingham back in 2020. And that was the first real-world deployment of AI in a clinical pathway. Now, at the time, it was a Class 1 medical device, so it sat always with a human in the loop. The AI kind of acted as a sorting hat for which patients saw a trust dermatologist and which ones could be viewed by our consultant dermatologist to safely discharge as benign out of the pathway. Since then, again, I won't touch on too much of our kind of clinical results, but since that partnership in 2020, we've brought on a number of other trusts. So we work with 8 trusts in total, and we sit in 3 different pathways. So as the colours are terrible on here because they're really pale, but to differentiate, we have one model in primary care in Mid and South Essex where we act as a decision support tool for GPs, so at the start of the pathway. But most of our partnerships, the likes of University Hospitals Leicester, Bristol, Chelsea and Westminster, Ashford and St Peters, and East Suffolk, all we sit in the secondary care pathway, so post 2-week wait referral, acting as a triage. And then the last pathway that we've just recently launched with University Hospitals Birmingham is a kind of pre-referral pathway. So we're skipping out that GP appointment, saving that GP appointment. The patient is booked directly into one of our AI hub appointments. The AI can do its triaging, and then what we aim to do is obviously catch more of those cancers that would have typically been put on a routine pathway, and make sure patients can get the specialist help that they need. Since launch in 2020, April 2020, which was also the start of the pandemic, I do not recommend launching a new AI cancer diagnostic pathway during a global pandemic. However, since we've done that, we've been able to see over 30,000 patients in the real-world setting and also close the loop on what the AI's performance was, which means we've been able to see what the AI said and what impact that's actually had. So typically, it allows us to discharge between 20 and 40% of patients out of that hospital pathway, which is pretty exciting. And then what we're going to do is talk more specifically, or Helen's going to talk more specifically around the impact that we've had on University Hospitals Leicester, which is actually the whole of the ICS, because one of the things that I'd want to get across here is that the AI is the AI, and it does what it does. Where we sit in a pathway very much depends on, honestly, system maturity. ICSs are relatively new. Obviously, some are working more closely than others. And I think one of the things that we want to show you today is the collaboration that Leicester and Leicestershire and Rutland really showed with this innovative pathway on how you implement something over an ICS. So in that case, I'm going to hand over to Helen and she can take it from there.
Hello, I'm Helen Mather and I am the Associate... Is it still on? Oh, I'm the Associate Director of the Elective Cancer and Diagnostic Services across Leicester, Leicestershire and Rutland. I can't forget Rutland because they get very upset if you do. And basically, I'll stand over here. We've been working on dermatology pathways for some time, and prior to ICSs, truthfully, because we were trying to work more collaboratively. We should have 15 dermatologists, and we've got 7.5 in LLR, so you can imagine that gave us a number of problems. So what we did was we worked very collaboratively with the GPs, and we actually have trained and developed 11 what was the old GPSI, but is now a GP wonderful terminology, but it's a GP with a specialist interest. And what we did was work very closely with the dermatologists to develop this training program, and also they're all mentored by a dermatologist, and they are part and parcel of MDTs, etc., so that actually we get the training right. And the other thing we did is develop a GP training program that runs every year, 8 sessions a year for basic dermatology, that again then supports the system going forward. So we've seen, as you can imagine, well, pre-COVID, we were hanging on to the targets by the skin of our teeth, as were a lot of places. And we had seasonal, as you would imagine with dermatology, ups and downs, especially in the summer, etc. But we've then seen a further 30% growth above pre-pandemic levels, which of course has had a big impact on our provision. The conversion rate, so people say, oh, well, the referrals, well, GPs will be, you know, trying to move patients to be seen quicker by putting them as 2-week wait, but actually that was not the case, because our conversion rates went up from about 5 to 7 to now, you know, anything between 12 to 15%. So that sort of scotched that myth, which was very useful. I've talked about the number of consultant availability, and we have got some dermatology nurse specialists as well, and we have been growing that group of professionals. We've got one of the problems, what we saw was, as we took the 2-week waits, the capacity for non-cancer patients really declined. So our RTT was then badly affected. And you've got all these patients with other dermatological conditions who were waiting even longer, which again wasn't acceptable. So we are one of the busiest, 4th busiest in the country, and as I say, we're on demand. The other thing we did manage to do, though, one of the GPSIs that we had, they've actually fully trained and they're now a consultant. So we have used the GP workforce to actually help, because of course you can't, you know, I mean, dermatologists don't grow on trees. So that even if I had the money for 15, I'd never be able to appoint them. So that's where we are. For LLR, we have got we've got areas of real depravation, and also areas where we've got lots of inequalities, both in the city and in some areas in the county. And although people think Rutland is really wealthy, and parts of it are, there were 40,000 requests for food packages last year, because actually there is deprivation even in the wealthier areas. So what we've looked to do is how could we do this collaboratively? So we'd already introduced what we call referral support triage for dermatology. So every dermatology referral that wasn't a 2-week wait went through an RSS, which was manned by the GPSIs. And we did then have an element of a deflection back to the GP, but also referral triage at that point into primary care, which did reduce the amount going into UHL by about 200 patients a month. So you can imagine what it'd have been like if we didn't have that in the plan as we stood. So we were trying various things. We also improved our referral pathways. We use a system called PRISM, which is a referral management system. It's not perfect, but actually it does help direct the patient to the right place at the right time. We'd been reasonable pre-COVID on our targets, but actually during COVID we did see quite a dramatic drop in our performance in both 2-week wait and RTT, and that's only just getting back, and I'll show you some of those results now. Better patient experience. One of the things is patients, if the actual service ran out of the busiest hospital in Leicestershire, which was bang in the city centre, the LRI, and parking was about £4.50 for every 2 hours. Patients didn't like landlocked, not easy to get to, and as I say, expensive from a parking perspective. So in truth, it wasn't really the best that we could do, looking, if we were going to change what we were planning. So we'd looked at various things. So dermoscopes. I must have purchased more dermoscopes than you lot of ad hoc dinners for primary care, etc. Found lots of them in drawers because in truth the GPs didn't feel comfortable using them. We'd done training, etc. The GPSIs of course use them all the time, but it wasn't the panacea of all ills. We'd looked at outsourcing and insourcing. So outsourcing, everybody talks about that in all range of specialties, and we have managed to do it in some areas, but in truth, most of our surrounding health economies were also struggling, so that really wasn't an option. And we were, to get actually any more consultants in, we were struggling, so that was not going to be a suitable option. Teledermatology, the consultants historically have been very concerned that the pictures weren't good enough, and so there'd been a reticence around teledermatology within LLR. So we then, I think I was at a conference or something where actually skin analytics came up and what they were doing in Birmingham. So we went to Birmingham and we looked at this because we really needed, A, to get the patients seen as quickly as possible, but also to create some capacity for the ordinary patient with a dermatological condition so they weren't suffering for longer than was needed. So this was what we then did. So we looked at this, and luckily enough, I managed to get some funding via one of my East Midlands Cancer Alliance that they actually has helped us set this up from a funding perspective, because we all get an annual amount to cover any changes. I took it through the system, so it went through the University Hospitals of Leicester. I took it through the it was the 3 CCG boards at the time, because we hadn't quite become an ICB at that time. I took it through all the clinical reference groups and everywhere to socialise it so that people understood. The other thing we did was a really big piece of focused work, because as you all know, if the dermatologists weren't on board, we were going nowhere fast. And really, they they grasped this with both hands, I think because of the results and what they'd seen, because they went to Birmingham to look at it, and that was really one of the clinch points. So if you're looking at this, definitely do that with your dermatologists, and they were really, really keen. We also made sure that the GP dermatology, GPs with an interest in dermatology also were supportive. So it was getting your teams on board. That was quite a key part in this. So then we looked at, so what does that mean? And who needs to do this? So the referral came out, and we've done the work around making sure that the patients, the GPs know how to do it, how to refer, what to do. And because we'd got a referral support service already in place, it made it a lot easier to do. So the GPs, in effect, didn't have to change their patterns of referral, because you know that doesn't happen overnight. And then what we did was we looked at, with Skin Analytics, training a range of healthcare assistants and saying, right, where do we want this service? Because we don't want them to go to that big building in the middle of the city, but we do need a city provision. So there is a hospital called the Leicester General Hospital, which is on the outskirts of the city, and they do it out of there. But what we've also done, we've got a number of community hospitals. So actually, we've used those because they're well spread, as you can see: Market Harborough, Melton and Rutland, Charnwood, North West Leicestershire and Hinckley and Bosworth. So we've got a really good spread of clinics. We didn't bring them all online at the same time. We started off with Loughborough, and then we've moved it round because it was about getting the model right first time, and everybody conversant with that. There was nervousness about HCAs doing it. There was nervousness about the AI itself, and people were going, but I'm still liable. So we did a lot of work on how do we get everybody to feel comfortable with this, and what can we do to make sure that we can check the results. And so through Skin Analytics, we have a second dermatology check. So, and that hopefully will only be for another year, just to actually provide that transparency and assurance that they're not going to miss a patient, because that's what their worry is, that a cancer will get missed. So when we looked at this, as you can see, so you can see the volume of referrals in 21 and 22. You can also then see the 2-week waits. And as you can see there, we've seen improvements. So, you know, we were at 18.2% in June 21, diabolical performance, whereas we were back up to 90.6 by the same period in June 22. And at the moment, I think the latest one is we're at 92.5. So we're getting there. RTT, again, we really dropped in performance in 21. So, you know, we were having patients waiting 52, nearly 78 weeks for their first outpatient appointment. You know, and these patients with psoriasis or whatever were suffering while they were waiting, and that wasn't acceptable. So again, with the capacity released by this, we've been able to get that back up to, we're about 8, I think we're near 89 this month, which is a lot more towards the absolute target. The other thing just to say is we ended up being able to, 63% of our face-to-face referrals were avoided. That gave us the capacity to see the non-cancer patients, and 20% has been discharged by the AI itself, and then a further 10% with AI and review. So that's been really, really beneficial. So it's collaboration. So what we've done here is, so I'm the meat in the sandwich. My role is to actually bring all the partners together, and that includes the clinicians, because without them, you're lost. So in truth, my background is I'm a nurse by profession, but I've also worked in the acute trust. I've worked in a few, but I have worked in LLR's trust, and that did end up helping because I knew a lot of the dermatologists. But in truth, it was getting them together, working with Skin Analytics to convince them that this was the right way forward. Because AI is still new. There's still a lot of nervousness about AI, but I firmly believe that if without using these technologies going forward, we will not cope with the workload and provide a good, responsive service, and we need to be doing that. We've also worked with the CCGs, and also we had a thing called the Alliance, which was primary care, UHL, LPT, that's Leicestershire Partnership Trust, and their community and mental health. And we use that vehicle to get that bringing together of a vision. So it was a proper ICB vision, and it has been stuck to. And to be honest, everybody is really keen. The other thing that's transpired out of that is that actually the East Midlands Cancer Alliance is really keen. They are looking at how we can do this across the East Midlands, so Derbyshire, Nottinghamshire, Lincolnshire, and possibly the West Midlands as well. So we've got a comprehensive approach. So we looked at funding. Pilot funding via EMCA, so I'm quite good at getting money after 48 years in the NHS. I can wheedle something out of most people one way or another. And I've managed to get that funded for this year and probably next year, while we just really get everything embedded and work through. And then I've already started the conversations about mainstreaming this as part of normal business as usual, because you have to give them a bit of, the directors of finance et al., they need a bit of time to acclimatise, don't they? So we've got there. And then what we're looking to do is say, how do we then extend that, move it forward? If we can get it streamlined across the East Midlands, we could come up with a funding model, a generic one for that. Streamlining the pathway. So we found a few glitches as we've gone, like you do with anything, how we do that and do that going forward. And extending to other sites, because it is easy, it's transportable. Healthcare assistants can be trained, they find it is really good from a work satisfaction, and the patients love it. We've had really good feedback from patients, and we collect that every time. So we are continuing to do with Skin Analytics evaluation on a monthly basis, and we'll be doing a year sort of evaluation at the end of March. And that really completes what I wanted to say about this. It's an excellent project for using how we can all work together across, because we need to.
Excellent. Thank you to Rachel and Helen. And that is the last panel of Giant for this year. I hope you've enjoyed it, and we'll see you next year.